Welcome. Today's question is, why should I test my dental unit water lines? Together, let's uncover waterline basics, the main reasons for testing, the consequences of unsafe water, and the effects on your health, as well as your responsibility as a dental professional. The reasons an office should perform dental unit waterline testing basically fall into the following main groups: the safety of everyone in the dental office, including yourself, your coworkers, and your patients. We want to be compliant with the guidelines made specifically for us, designated by experts in the industry. We want to show our responsibility through testing and documentation. We want proof our waterline protocols are effective and our office is following them. As the cup fills, you and your patient may be thinking the same thing. Is this water safe? You protect yourself and your patients at every visit. You wear protective equipment, you sterilize instruments, disinfect surfaces, etc. You protect and prevent at each stage of the visit, pre and post visit. But what about the water you're using? Has this been overlooked? If you truly want to close the infection control gap, you must include water lines. Every time you perform a routine job like scaling, where blood and exposed tissue are common, you are creating entryways for infection. You use sterilized instruments, you wear gloves, a mask, you disinfect the patient's mouth, all of this in name of infection prevention and control. Then you introduce an uncertain source, the water. The Centers for Disease Control and Prevention state, exposing patients or dental health care personnel to water of uncertain microbiological quality, despite the lack of documented adverse health effects, is inconsistent with generally accepted infection control principles. We have known about the consequences of unsafe water for decades. How many of these cases do we need to experience before we take serious action? Unsafe dental unit water can affect the young, the old, it can make you sick, it can be fatal. Listed are some well-known cases over the last 30 years, at least the ones we know about. As it can be difficult to trace illness or death from unsafe dental water, who knows what hasn't been reported? Who knows what the true effect of unsafe water actually is? Let's start at the beginning. Why does biofilm or bacteria grow in your water lines? Dental unit water lines are small, long tubes with minimal amounts of water, which only flow for short amounts of time when in use. Otherwise, the water is left stagnant throughout the day. These factors, combined with poor maintenance protocols, make the insides of a water line an ideal environment for a biofilm bacteria party. The biofilm that forms in your water lines is so much more than just slime. It helps bacteria colonize and multiply, shielding it from disinfectant attacks and from being carried off as the water flows through the lines. Microorganisms attach to the inside surface of your water lines, and they grow there protected by the biofilm. They continue to grow and multiply. When these colonies become quite large, a piece breaks off and is carried down the water lines, where it finds a new home or is carried right into the patient's mouth. Or even worse, it becomes an aerosol. The life cycle of biofilm is just like the life cycle of a human community. Think of biofilm as a wedding party, with lots of different microorganism guests, eating and having a great time together. Eventually, the bride and groom and their guests break away from the party and go back to their own homes. There, protected by a home to keep them safe, fed and warm, families grow and multiply until there's another wedding, and then it all happens again. Let's take a closer look at our uninvited dental unit water line guests that can make our water unsafe. It is common for dental unit water lines to be contaminated by many species of microorganisms, including 28 species of bacteria, 5 species of fungi, and 4 species of protozoa. Some of these are more harmful than others. In our diagram, the larger bacteria, like Legionella, are more dangerous. The consequences of transmission can be varying: a simple and quick upset stomach, hospitalization, even death. Dental waterline microorganisms can be transmitted through ingestion of contaminated water being flushed into the oral cavity during treatment or inhalation of aerosols. The mode of transmission also affects how dangerous a microorganism can be. If inhaled, Legionella, mycobacteria, Pseudomonas, and Aspergillus form biofilm in the lungs, causing pneumonia. All of these, along with Klebsiella and Cryptosporidium, can also be extremely hazardous when they enter the bloodstream and produce toxins causing infections requiring hospitalization. But swallowing Klebsiella or Cryptosporidium causes mild, temporary symptoms like vomiting and diarrhea. As there are so many different kinds of species lurking in your water lines and so many ways they can make you sick, it's not worth taking the risk of having your water lines home to any of these microorganisms, harmful or not. Water testing is the only way to know if your water is safe to use. If your water is contaminated, biofilm and/or bacteria will be released every time you turn on the water or use a handpiece. However, not only do you need to be concerned about the potential dangers coming out of your water lines, but also what may be coming in. Contamination can occur during suckback of oral fluids from a patient from a failed anti-retraction valve, when equipment is turned off, or when handpieces are removed and replaced incorrectly. Even with dental handpieces equipped with anti-retraction valves, studies show contamination despite the perfectly functioning valves. Another study tested 117 dental unit sites and found 72 to 80% of the lines contain microorganisms from the human oral cavity. These are not native to water. This concludes that biological fluid retraction into dental unit water lines during patient treatment may be more frequent than we expect. We decided to see for ourselves and tested the water from a Cavitron. 152 species were detected, including various bacteria typically found in the human mouth or respiratory tract, E. coli and other parasites typically found in stool, and even parasites usually found in the mouth of a dog or a cat. These highlighted bacteria or parasites are not normally found in water. They prefer much warmer environments. The only explanation is that they were sucked into the water lines from a patient's mouth. It was bad enough to have waterborne bacteria. Now you know there's added danger incoming from other sources. Even more reason to test. Regardless of what is inside your lines, it can all be released in the form of aerosols. Aerosols are produced from using rotary instruments, air abrasion, air water syringes, ultrasonic scalers, and during air polishing. These microorganisms could negatively affect the health of dental professionals due to exposure to aerosols, which may be inhaled. As we have previously noted, swallowing some of these microorganisms is likely to be harmless or mildly symptomatic. However, if they enter an open wound or find their way into your bloodstream or are inhaled, the consequences can be more severe. Aerosols are defined as particles less than 50 micrometers in diameter. Their danger is due to their tiny size, allowing them to remain airborne for long periods, readily available to be inhaled. The water from a high-speed drill creates a 4-foot diameter circle of potentially contaminated aerosols. Personal protective equipment, such as a mask, can provide protection. However, if your water is contaminated, anyone in that circle risks inhaling potentially hazardous microorganisms and particulate material due to aerosols production. This explains the potential connection noted between dental water contamination and respiratory disease transmission among dental professionals. High counts of Legionella antibodies were found among oral health professionals, which may be subclinical infections likely due to the chronic exposure to Legionella-contaminated aerosols from dental unit water lines. One study found that the onset of asthma in dentists may be associated with occupational exposure to contaminated dental unit water line. In 1994, a dentist's death from pneumotic Legionella was attributed to the inhalation of the pathogen during use of handpieces. There have been isolated cases of amoebic eye infection, brain abscess, and gastrointestinal disorders reported, which may be related to the exposure to contaminated dental unit water lines, but evidence is lacking. Let's move on to what standards have been put in place to reduce the chances of contaminated dental water. There is a hierarchy of governing bodies and documentation that form the dental waterline rules. There are industry standards that need to be met, and of course, the guidelines provided by the manufacturers themselves. In our case, the manufacturer's instructions for your related equipment and waterline treatment products. All of the above are based on the same main principle. The dental industry has agreed to the following standards: less than 500 colony-forming units per milliliter of water, 0 E. coli per milliliter, 0 total coliforms per milliliter. Maintaining these standards without doing anything would be impossible. You may ask yourself how quickly even the best water quality can become unsafe. Most dental units are self-contained water systems using an independent water reservoir or bottle which isolates the unit from the municipal water. This isolation allows control of water quality in your dental unit. These systems are either part of the original dental units or can be retrofitted to most dental units. As we see from this illustration, the use of an independent reservoir without the use of a chemical water treatment can produce unsafe water very quickly. Look how microbial counts in the newly installed dental water lines can reach as high as 200,000 colony-forming units per milliliter within just 5 days. That's 400 times the recommended water quality limit. This enforces the key role of maintenance, shock, and of course, testing. Although the incoming water from an external source is sanitized and meets public health safety standards for potable quality, water coming out of the water lines may eventually contain up to 1 million colony-forming units per milliliter. And of course, let's not ignore the possibility that the original water source can be contaminated, even before entering the water lines. The fact that bacteria multiplies with incredible speed does not help the situation. E. coli, for example, doubles every 20 minutes. If you haven't got the idea yet, biofilm and microorganisms are extremely hard to control in your water lines. Even with the current methods of disinfection and flushing guidelines, levels have still been found to be inconsistent with potable water. So what can we do to keep our dental unit water lines in check? The ADA, CDC, and manufacturer's instructions all have ways to reduce the formation of biofilm and bacteria. We are aware of the possible dangers and consequences. Let's make sure we're doing everything we can to close the infection control gap. Ensure all staff have received training regarding water quality, biofilm formation, water treatment methods, and appropriate maintenance protocols for your water delivery system. Ensure water lines are monitored for damage and/or any visible contamination and replaced as needed or as directed by the manufacturer. Waterline heaters are not to be used. Sterile water or sterile saline is used when irrigating open surgical sites and whenever bone is cut during invasive surgical procedures. Appropriate devices such as a bulb syringe or single-use disposable products are used to deliver sterile irrigation solutions. For offices using closed or other water delivery systems, follow the manufacturer instructions related to dental units and equipment for daily and weekly maintenance. Follow manufacturer instructions regarding testing, maintenance, and preventive maintenance of lines, anti-retraction valves, and other accessories. Dental unit water lines should be flushed for a minimum of 20 to 30 seconds between patients to discharge oral fluids that may have bypassed anti-retraction valves. All water lines and handpieces should be flushed for at least 2 minutes at the beginning of the day to reduce the bacterial load from stagnant water conditions that may have occurred overnight. We know there is a lot happening inside our water lines. Is line flushing enough to rid of the bacteria and biofilm? A review of 4 studies concluded flushing water lines for a few minutes may reduce the concentration of small floating bacteria. However, flushing was not able to remove the biofilm. Flushing, like microfiltration, removes microbes that have budded off from the mature biofilm, but it is unable to remove the microorganisms present in the biofilm that have adhered to the walls of the water lines. The studies also found that flushing was relatively ineffective in removing Legionella and Protozoa from the dental unit water lines. This is all in line with the Centers for Disease Control's guidelines, recommending that flushing alone is not a reliable procedure for improving water quality. In fact, additional methods to flushing, such as the use of chemical agents, are necessary. We know what we can do as dental professionals to reduce the chances of contaminated water. But do we do them? And all the time? People are human. Mistakes happen. We get busy. We can forget. A survey regarding dental unit waterline disinfection was distributed to dental assistants and hygienists, asking if they flushed the lines and placed tablets in the bottles when recommended. Over 85% of respondents reported placing a disinfectant tablet in every water bottle refill. About 22% reported flushing the dental unit water lines for 2 to 3 minutes every day. Only 19 reported flushing the lines for 20 to 30 seconds between every patient. So what about the times the tablets weren't added or the lines weren't flushed? Every dental unit waterline scenario is as unique as you are. Not all waterline treatments and protocols work equally for every office. There are so many variables to consider, such as the type of the treatment you're using, the type of the equipment, the age of the lines, the type of the lines, how often they're being used, the number of lines per bottle, the source of the water, and the list goes on and on and on. We have just seen that even with office waterline protocols in place, there's no guarantee the protocol is followed. So how do you know for sure your water is safe? How do you know for certain that what you're doing works? How do you justify your time, your money, and your efforts all spent towards dental unit waterline care? How do you show your responsibility to close the infection control gap? The only solution is to test. Testing is like having dental water insurance. Remember to always record. According to OSAP, you should keep these waterline records for 5 years. Recording protocols and test results protects your office. This is office liability. Proof you are doing things right, that you're being responsible, you're taking preventative action to protect yourself, your coworkers, and your patients. Testing is awareness of your current waterline situation. It provides opportunity for continuous improvement. In the case of failed tests, it's a record of your corrective actions, your path to better protocols, and improved water quality. Testing is an essential indicator providing your safe water assurance when the factors working against this goal are numerous and unpredictable. After understanding the many variables involved in achieving an acceptable quality of water, I don't think this should come as a surprise. A study of 22,000 waterline tests found that 31% of treated waterlines failed to meet the standard of less than 500 colony-forming units per milliliter, despite some efforts toward waterline care. Additionally, 61% of practices had at least one failed waterline. Not only does testing make common sense, it's recommended by industry experts as they fully understand the complexity of dental waterlines. OSAP recommends that monitoring be performed periodically, regardless of the product or protocol used to manage dental procedural water quality, even when manufacturer directions for monitoring are absent or unclear. When there are no manufacturer directions available for dental units, OSAP recommends that periodic monitoring and inspection should be performed according to the directions for use provided by the treatment product manufacturer, or at least monthly on each dental unit or device. If monitoring results indicate water quality is acceptable for 2 consecutive monthly cycles, the frequency of testing may be reduced, but should never be less than every 3 months. To conclude, we have seen the many faces of unsafe water, and that even taking care to address them all, water test results may still be unacceptable. This poses a real risk to the health of anyone in its path. Testing ensures a responsible and safe working environment. It is part of the industry compliance and manufacturer instructions. It provides office liability through documentation, and it allows preventative infection control. Close the gap to all your efforts and please test your water. Thank you.